Hi, everybody, and welcome to the webinar that we're about to start to give you some updates on ABEM's new certifying exam and the program director attestation. My name is Diane Gorgas. I'm chair of the Test Administration Committee, and with me today is Ray Johnson, the president of ABEM. I'm going to turn it over to Ray for some introductory remarks. Thanks, Ray.
And thanks, Diane. On behalf of ABEM, I want to welcome and thank all of you for attending the webinar today. Since the announcement that ABEM is planning to have a new certifying exam, there have been many questions, not only from residents, but from our volunteers, diplomats, and program directors. First, let me reassure you that the decision by the Board of Directors to pursue a new certifying exam came after a tremendous amount of due diligence, debate, discussion, and reflection. So thank you for bearing with us as we give this webinar today. You know, ABEM's mission statement states that we want to ensure the highest standards in the specialty of emergency medicine. And one of our strategic objectives is that the in-training examination, initial certification, and MOC processes will meet the highest standards of the certification community. When you look across the American Board of Medical Specialties, 14 boards actually have oral exams. 4 are virtual, 8 are in person, and several of them are actually looking to transition back to an in-person environment. And 2 boards are in the early stages of thinking about incorporating a new practical exam. When you look at our background as to how we got to where we are today, the Becoming Certified initiative gathered extensive feedback, which included focus groups, surveys, and even a summit meeting from stakeholders regarding all aspects of the initial certification process. This endeavor actually encompassed over 4,000 individuals as we went through this process. And the findings of that group came up with the following: that we must maintain high standards, that the qualifying exam was essential to initial certification, that the oral exam is good and it is valid and reliable at measuring competencies that are not measured by the qualifying exam. There are some virtual oral certification exam issues that are subject to security risks. We also felt that additional competencies need to be measured by whatever new certifying exam we produce. And the format for evaluation must be flexible, adaptable to changes in medicine, and not be able to be replicated by AI. With that background, I'd like to turn the meeting back over to Diane to do a deep dive into this new certifying exam. Thanks, Diane.
Thank you, Ray. Next slide, please. Just an overview of a couple of the things that we're going to discuss today. The first is the program director attestation. And then we're going to delve, like Ray mentioned, more deeply into the certifying exam. I'm going to give you an overview of the exam. We're going to answer the question of why Raleigh. We're going to talk about exam administration. We're going to talk about some considerations that we're coming to with moving to an in-person exam. And then I'd like to have ample time to answer your questions at the end of this. Next slide. But first and foremost, before we get into any deep discussion about the certifying exam or the PD attestation, thank you. Thank you. Thank you for being here. Thank you for seeking information about this. Thank you for taking this information back to your residents. A number of us on the board of directors, myself included, have been program directors in our careers. And we know that there's a lot of angst around change. And this is going to be a big change, but we're here to help you every step of the way. Next slide, please. So let's talk for a moment about the program director attestation, something that is required to have your residents graduate and be able to sit for the boards, including the initial qualifying exam, the written exam, and then subsequently the certifying exam or the oral exam. The program directors will be expected to complete the new PD attestation form for all graduating residents this year, so starting in summer of 24. Your answers for medical knowledge, patient care, interpersonal and communication skills, professionalism, system-based practice, and practice-based learning will not impact the resident's board eligibility in 2024. We ask that you complete the form based on the skills and abilities of the resident at graduation. But we also are really asking for your feedback on the form, because your feedback will help us improve the form for use in 2025. And there's a QR code here embedded in the slide that you can take a snapshot of and give us your feedback. Next slide. Your feedback will help improve the process and will help revise the form for years to come. Our goal is ultimately to have this attestation count towards board eligibility and the ability to take the qualifying examination. You are the experts in telling us that your residents are ready to take the certification initiative, the qualifying exam and the certifying exam. So we would like to put the power in your hands to tell us which of those residents are really ready to do this. Thanks. Next slide. So the big question that we're here to answer today, as well as why an oral exam? As Ray mentioned, most ABMS boards have an oral exam, the majority do. And most of those boards have an oral exam that they conduct in person. Most of the boards as well have a written examination that really focuses on assessing cognitive skills and medical knowledge. But an oral exam's power comes in that it can assess other complex competencies, such as restraint, resource utilization, complex multi-step reasoning, thoughtfulness, interactions. And there is definitely a correlation between the qualifying exam and the oral certifying exam. But the oral certifying exam, or the certifying exam, as we'll be calling it in the future, is discretely different at the same time. Next slide. So how did we get here? And how have we come to this decision that our certifying exam needs to be more robust? Over the course of 2 years, we had a Becoming Certified initiative that looked at all aspects of initial certification. We sought active and engaged feedback from stakeholders. There was a stakeholder advisory group, in fact. But these stakeholders included, as Ray mentioned, over 4,000 ABEM certified physicians, program directors, residents, employers, hospital and health systems, representatives from every major EM organization, and ABEM volunteers. And there were multiple input modes that we used to gain this information: surveys, focus groups, interviews. We developed and still maintain a stakeholders advisory group. And this kind of culminated in a summit where we brought representatives from every neighborhood, every house of emergency medicine to Chicago to talk about the future of emergency medicine and what certification and assessment really needed to look like to encompass that future. Next slide. As I mentioned, the stakeholder advisory group was set up at this point. It's comprised of community physicians, academic physicians, program directors, early career physicians, some of us old gray hairs around that as well, some volunteers, some EM organizational leaders, a resident member, public members, and the whole idea of the Stakeholders Advisory Group, the SAG, is to provide input during this entire process. They reviewed content and data, and they have, along with the summit, identified the priorities for the process to certify physicians. And if you can go to the next slide, I don't expect you to read any of this, but from the summit in Chicago, participants were asked to write down their one big idea about becoming certified. And this has led to not only a collaborative, but a very deliberative process to really stake out what we think is important in the certification process and what the public and what our diplomats think is important in the certification process. You can go to the next slide. So the findings of the Becoming Certified initiative are that all aspects of the process for becoming certified were reviewed and evaluated. And the number one thing that we have to come away with is that we must maintain high standards. The qualifying or the written exam is important for certification, and the oral exam is valid and reliable exam in the process, but that at the same time that we were maintaining these high standards, there was certainly a need to assess additional competencies. So we sought to create an assessment that more closely really reflects the skills that emergency physicians use in actual practice. And hence, next slide, we will be launching the new certifying exam in 2026. Next slide. So why a new certifying exam? In this exam, the candidates will have the opportunity and the need to demonstrate skills and abilities that are not measured in the written exam. Some of these additional competencies are critical to emergency medicine and to the public that we serve, including procedural skills, including manual ultrasound skills, the art of prioritization, demonstrating patient-centered communications, having high stakes or difficult conversations, managing conflict, and being able to manage a team as well. Next slide. So what is the new exam? What's it going to look like? The certifying exam will take place in Raleigh, North Carolina, at the AIM Assessment Center. This is a professional assessment center, but it is not a simulation center. The difference between the two, a simulation center, really is high tech and uses on a cutting edge sense new education strategies for learners. This is a center that it is unique in that it's a space to accommodate different types of cases, provide uniformity in administering cases to all candidates. It'll be a uniform environment with the same on-site resources for everyone, and it's configured just as an assessment center. There is actually a deep dive into why Raleigh explanation and factors on the ABEM website, www.abem.org. Utilizing the center in Raleigh will allow us to have more administrations throughout the year and greater scheduling flexibility for candidates. There will be two types of cases. Thanks, perfect timing on the slides. The first set of cases will be clinical care cases. These are facilitated by an examiner, and they will allow candidates to demonstrate how to prioritize patient care. They'll be able to assess the candidate's ability to manage unexpected clinical changes and to interact with various sources of information. The OSCE cases, or the small room cases, will be able to assess one-on-one communication, assess some issues of professionalism, and essential technical skills needed to care for patients. So the oral exam as we know it now, the virtual oral exam, will be administered through 2025, and the certifying exam starts in 2026. So if your residents are graduating in 25, they will take the new certifying exam. And if your residents pass the qualifying exam in 25, they will take the new certifying exam. We can go to the next slide. There's even a more detailed representation of this. So what describes your current situation, or what describes your learner's current situation? For those residents that graduate in 24, they optimally will pass the qualifying exam in 24, pass the current oral exam or the virtual oral exam in 25, and become ABEM certified. If your residents will graduate in 25 or did not pass the 24 qualifying exam and they need to retake the qualifying exam, that optimal timeline will be to pass the qualifying exam in 25, then pass the certifying exam in 26, at which point they will be ABEM certified. If you are already ABEM certified, you only have to do your continuing certification requirements. You do not need to take the certifying exam or travel to remain certified. And if you're a program director, keep this QR code in mind. Stay informed. The details of what we're going to be talking about are available here. So great. Let's lean in a little bit more to why Raleigh. We understand that it's on one coast of the country and is not centrally located, but after doing extensive looks around the country for assessment centers, Raleigh really is a one-of-a-kind, custom-built assessment center. It's a site for other high-stakes certification examinations, as opposed to, like I said, a typical simulation center that is really used for high-fidelity simulations. This is an assessment center. Its administrative infrastructure has already been developed, and it can accommodate a variety of case types: clinical cases, procedural cases, simulation, and we anticipate in the future even other case types. At Raleigh, we have access to a trained, very interactive, and very skilled set of standardized patient actors that represent the entire diversity that is emergency medicine and who we see in the emergency department. These standardized patients are trained for high-stakes certification exams. They are not scores or judges in the process, but they're crucial for the success of the OSCE portion of the exam. From the candidate experience, it will be uniform. The candidates will register at the candidate hotel. They'll be assigned proctors who guide the candidates through the logistics, and the candidates just need to get to the hotel on the assigned day and time to get wrapped up in the entire logistical process. Here are some pictures of the assessment center at Raleigh. That there are clinical case rooms, simulation and procedural or OSCE cases. And up in the upper right of the slide, you can see there's the tabletop cases or the clinical decision cases will be given in much more of a format that you, as ABEM diplomats, are used to seeing during your oral exam. It's important to remember, and please spread this information far and wide, that no ABEM director financially benefits from exams at the AIM Center. The AIM Center is an independent LLC. It has its own board of managers. The American Board of Anesthesia is the organization that staffs and helps maintain the board of managers and the AIM Center. And the ABA directors and physicians are not participating in the development and administration of any of our exams. They're there for our logistical supports, but this is purely an ABEM product that your residents and learners will be engaging with. One of the great advantages of using the AIM Center as well is that we are able to give a lot of different tests throughout the year, a lot of the same tests at different times throughout the year. There'll be 9 administrations per year to start. This is the number necessary to accommodate all residency graduates. The days of administration are going to run Monday to Thursday, and there will be 2 sessions per day, both a morning session and an afternoon session. Within those sessions are actually 2 80 to 90-minute blocks. So the entire testing time is about 3 hours, and the residents will the former residents who are now candidates will either be assigned to a morning or an afternoon block on a given day. The clinical cases or the tabletop cases will be 15-minute cases. There will be 4 cases per session. And there will be 2 examiners in each room who will both be scoring the cases independently and will be working in a dyad so that experienced examiners and newer examiner teams are made up so that there will be some longevity in our volunteer training. The other type of clinical decision-making cases are the prioritization cases. Some examples of this are that the candidates may be asked to approach a track board that has 5 to 7 new patients on it with their vital signs and their chief complaints, and have a discussion with, perhaps a triage nurse or a charge nurse who's working that time about which patients they want to see first and what they want to do with those patients, and how they may be able to have ancillary care come in and help deload or help with assisting getting to those patients. It also may be triaging of multiple patients arriving without warning, or a patient with multiple injuries or multiple illnesses, and the way that they need to approach those patients needs to be prioritized. The clinical decision-making cases, to contrast from this, are very much like what the residents do with you on a day-by-day basis when they would take the information of a case, present it to you, and then you may ask why they're ordering certain tests or what their differential is and what treatments they want to order. This would be the element of the new certifying exam that is most similar to the virtual oral exam that we currently have. So looking at those standard cases and structured interview cases. Thanks. To dig a little bit more deeply into the OSCE cases, they're going to be 10 to 15-minute cases with 5 stations. Examiners will score in person for the procedural cases, and there will be a cohort of examiners that score asynchronously for the other OSCE cases. The content areas that will be covered in this are troubleshooting, having difficult conversations, managing conflict, procedural ultrasound, but also procedural other, including the key core procedures of emergency medicine. And then a deep focus on patient-centered communications as well. So a sample case schedule would be that if this was during the morning session, a candidate may end up being assigned to the clinical cases first and go through the first 4 designated clinical cases, and then they will transition over to the OSCE cases. And there may be a troubleshooting case, a managing conflict case, an ultrasound case, and 2 patient-centered communication cases. In the afternoon, the case makeup will be similar, but some elements of that will be swapped out, including the specifics of the clinical cases and the specifics of the OSCE cases. So truly, the million-dollar question that all of your residents are asking and you as program directors are asking is, how do I prepare my residents? Truly, this assessment is designed to examine what an attending physician does every single day. You should be able to walk out of a shift in your tennis shoes and in your scrubs and into the exam and feel like there is a seamless really pathway from what you do on a day-by-day basis to what you're seeing assessed in the exam. So the best prep is truly to learn emergency medicine. Typically, be wary of mythology from board prep courses. It's often wrong and is designed around the contextual, frankly, false context of a virtual type of oral exam. This is really meant to strip away those walls and give us the best assessment on these higher order skills of what your residents and what the new candidates are doing on a day-by-day basis. So we're in the process of developing videos. There are going to be videos on candidate logistics, where to go, and when. There's going to be a walkthrough of the AIMS Center. We will have examples of sample cases and the environment in which you will be seeing those sample cases administered. And all of these videos should be available in the fall for you to look at and for us to be able to share with candidates that are coming forward. I'll also say that ABEM is run on the backs of its volunteers, and there are many volunteer roles. If you have no one in your program who is an ABEM volunteer, we strongly encourage you to put somebody in your program forth for being involved in the new volunteer roles with the certifying exam. We need case developers. We need on-site clinical case examiners, on-site procedural case examiners, on-site backup examiners, and we need a large cohort as well of remote examiners. So all of these are potentials for volunteers. If you know of people who would make a great volunteer but really don't want to leave their hometown, we have that capacity to use them in a remote volunteer role as an examiner. If you know of people that are just dying to get to Raleigh, North Carolina, we have that capacity for those volunteers too. So what's next? as I mentioned, we're going to be continuing with the virtual oral exam through 25. That's 2 more years or 6 more administrations. In the meantime, we will be having periodic webinars and updates for the certifying exam for programs, residents, and the EM community at large. And absolutely, we will keep you informed. Some upcoming opportunities to be able to interact with us one-on-one and also be able to hear some dedicated information about this is during the Cord Academic Assembly on March 27th from 12 to 12:45. There will be a dedicated session, and immediately after, ABEM is going to have a separate room staffed by directors to answer your program director and program-specific questions. We'll also be attending AAEM Scientific Assembly, and April 27th through May 1st is the date of that meeting. We'll be having a live information session with AAEM and RSA during this time, and details on the exact timing of this will become available soon as well. And to all of you that have kind of a nice concentration of residency programs in an area, or do you really want more information on this? Are you involved with a regional meeting or a conference? Are you a host of a blog or a podcast? Or if you know of opportunities where ABEM can provide an update on the changes to residents and core faculty, we are happy to give you that information. Just please complete the ABEM speaker request form. QR code is on the slide here, and we will connect with you to see what we can do to get you all the information that you need and want at your convenience. Thank you so much for your time, and I am here, as is Ray, to help answer any questions.
Thank you, Diane. We've gotten a couple questions in the Q&A, a couple about, of course, the center and the travel implications for candidates. So wondered if you wanted to speak to candidate costs. Will we have hotels, discount rates at hotels, et cetera, and kind of speak to the whole, because it's on the East Coast and you have our West Coast candidates, you know, ABEM's considerations around those travel expenses.
Yeah, we realized that, comparatively speaking, at the start of the pandemic, moving to a virtual exam, that the historical memory of any resident only goes back as far as virtual exams. Prior to that, any of you that graduated residency prior to 5 years ago or so, we all know that we all traveled to a location for an in-person exam at that time. So this is a financial burden. We understand for the residents that they haven't had for the last 5 years. There's a few things that we'd like to do to specifically address the East versus West Coast question with this. One of the things is that we can work with your former residents or now candidates to make sure that we can optimize the scheduling of their exams, so they may not need to, spend an extra day or be able to catch flights late in the afternoon, so that their travel time away is minimum. The other thing that we are looking at is the potential of helping to support travelers in any way that we can to get them to the assessment center. When it comes to the cost of hotels, because of the volume of this assessment, ABEM is going to be able to negotiate pretty competitive rates locally as well.
Another
Ray?
question, yeah.
I'm sorry, Ray, if there's anything that you have to add, please feel free to chime in.
No, thanks, Diane. Nothing to add.
All right, another question is, USMLE and Comlex discontinued their clinical skills exams. This feels very similar. So why is ABEM doing this when the USMLE got rid of that, this clinical skills step 2 exams?
A large reason why this kind of collapsed under its own weight for USMLE was the logistics and the practicality of it, and not the desirability. I think that this was always looked at as a very desirable assessment method to do an in-person assessment. It came down to ABEM, to how we were going to answer the needs of the community, the needs of employers, the needs of diplomats, and really assessing that critical skill set for emergency medicine. And after much deliberation, the board of directors really decided that there was no other way to do it except for in person. Now, there are clearly areas of assessment that we are going to delve into that we have never delved into before. And some of those areas were encompassed in program director attestations previously. But all of the stakeholders spoke in one unanimous, very clear, loud voice that the troubles that emergency physicians get into in their careers are not the medical knowledge issues. They are how they interact with coworkers, how they interact with patients, how they do procedures, what their kinesthetic competency or their muscle memory competency is like, and how they really troubleshoot and manage difficult and changing situations. None of those things can be adequately assessed in a paper and pencil examination.
So one of the questions is about the cases, the difficult conversation and conflict cases. How is ABEM going to safeguard against or limit or try to manage essentially unconscious or conscious bias? In terms of thinking about the candidate and examiner, gender and race, and how are we thinking about those things as we move forward with these types of cases?
That's a great question. And one thing I want to lean into here is that an OSCE exam is not scored on subjective criteria. The OSCE exams will be scored on very objective criteria. That there will be, in all likelihood, more than one reviewer of each OSCE interaction. And there will be set competencies that should be met in each of those witnessed encounters. So that should take away a large amount of the subjectivity or the bias that moves in, as well as having the potential for multiple scores on any case.
And Diane, I would add that we will be using actors who have been actually trained to actually role play in a way that we have never done before, where we will no longer have the examiners in those roles, but actually trained and paid participants who will act as actors, representing the types of patients that we see every day. And I think that will also remove a lot of the potential bias.
We've got several questions around the cost of the exam to candidates. And will there be an impact moving to this new exam in terms of the fee to take the exam versus what they're currently paying for the oral exam?
Yeah, another great question. There's no doubt that this exam will be more expensive for ABEM, but ABEM has very intentionally falsely kept the fees for initial certification completely stagnant, has not increased those fees over the last decade. And the reason for that is that we understand, we know that that we're approaching our future diplomats at the most financially unsure time of their careers. So we specifically offset the actual costs of the certifying examination into later assessment fees. We intend to keep the cost of the certifying exam, both the qualifying and the certifying exam, we intend to keep those static as we move forward to the new exam. It's a great question, though.
We've had a couple questions about whether or not this slide set will be available. I just want to let everyone know that this session is being recorded, and these slides and this session will be available to you, and we'll let you know when the recording is available. Another question is related to current residents who have been working towards and training for or preparing for the virtual oral exam. And so what do we do with those candidates that are taking they're going to be taking the virtual oral exam for 2 more years or 1 more year, really, can you speak and remind the program directors about that transition for those who have not passed the the virtual oral exam by the end of 2025? What will happen with those candidates who are still waiting for that exam?
Yeah, so it's going to be a full stop in December 31st of 2025. The virtual oral exam will go away. There will not be a tail if you're partway in the process at that point. If you have needed to retake, or if the candidate has needed to retake either the qualifying exam, the written exam, or the virtual oral exam and didn't pass one of those 2 components, then those candidates will roll over into the new certifying exam starting in 26. So again, does the new certifying exam require specific preparation that will unduly penalize those that are partway through the queue in 25 as we roll over into 26? Our hope and our belief is that it won't. You just need to train to be a successful residency graduate in your training program to gain the skill set that you need to be able to talk with patients and to manage conflict and to break bad news, and to do some procedural skills. And we don't view any of this as unique or specific training just for the test. This is all training that is done to be a successful emergency physician.
Will ABEM be sharing the scoring rubric for the new cases, similar to what we post right now online for the virtual oral exam standard and structured interview cases? Will ABEM be doing something similar to help program directors and educators help their residents so will we be posting that scoring rubric?
Yeah, there will be a new scoring rubric with the new certifying exam. And yes, we will be posting that. It is not nearly as complex as the scoring rubric for the current virtual oral exam, but the bones of that and what it looks like will be posted, associated really with each case type. Let me put it that way.
Can you talk a little bit more about the troubleshooting cases? Give a little bit more texture to what ABEM is talking about related to troubleshooting.
Sure. If you're working a patient up, or if you're the candidate working a patient up, and there are unexpected findings that are returned to you, if there is an unexpected change in the clinical course, if you need to pivot to be able to think about other conflicting information that is coming the residents or the candidate at that point's way. If there are lab test results, if there are X-ray test results that aren't making sense, if there's a twist, if the patient gives you additional information partway through a therapeutic that nullifies your initial course of action, how do you troubleshoot in that situation? How do you move forward and begin incorporating new information, or what you may consider as suspect information or unexpected information in a productive way in managing a case?
There's been a couple questions about examiners and how to volunteer, and we'll certainly can get you that information in terms of, and also the criteria. Generally speaking, volunteers need to be clinically active, ABEM certified physicians. But one of the questions is ABEM concerned at all with having enough examiners to keep up with the number of sessions that we have to have and the number of residents that we have?
Mapping this out, we have a robust group of volunteers for ABEM. Kathleen, you know this number probably better than I do, but it's over 500. volunteers with ABEM.
We have we have over 700, but 600 oral examiners right now.
Fantastic. Yeah, so we think that we're going to be fine with the initial rollout of this, but this is it is a calling. It's a calling to be an ABEM volunteer. You are giving of your time, and you are really investing in the future of emergency medicine. I can't talk that up for myself enough. It's been the pinnacle of my career, and for most ABEM volunteers, it turns out to be a really enjoyable experience, but we also want you to help carry that enthusiasm forward to your programs. Like I said, I'll double down on, if there is not an ABEM volunteer in your program, please contact us. Our goal is to be able to disseminate this information seamlessly to all programs, and we really help do that through our volunteers. So we would welcome the opportunity to have an ABEM volunteer for many of those programs that are not currently represented.
So will the prioritization cases resemble typical SIM cases, include mannequins, embedded participants, etc.?
Yeah, so the prioritizations are part of the tabletop discussion. So they could involve a track board, they could involve simulated patients in a disaster scenario, but there won't be multiple patients that you'll actually be seeing and contacting in a tactile way during that session.
Has ABEM put any thought into how program directors or programs can help candidates who fail this exam going forward, and how they can remediate in order to be successful?
Yes, so I think that this exam will be clear enough, and the content of the exam will be forward published enough that that candidates will have an idea about where they performed well in the exam and where they had some difficulties in the exam. The board is deliberating now on the granular feedback that candidates are going to get going through this process if they don't pass on their first attempt. So I can't give you details on that at this point, but I think that giving the candidates a good sense of forewarning about what the exam is and what it will look like will help programs appropriately emphasize and appropriately assess prior to their residents' graduation that they are competent in these areas.
So we've had a couple questions come in related to why we're doing this exam, given this is what ACGME residency programs are training candidates to do. And essentially, when a resident has been graduated, it should be assumed that they have these skills. So can we speak a little bit to why ABEM thinks that they need to do this if an ACGME program is sufficient and should be sufficient if a resident's already graduated?
Ray, I don't want to steal all the thunder here, but I'll just keep talking until you barge in, okay? The job of the ACGME is to accredit programs. The job of the ACGME is not to certify individuals. Even in the best program in this nation, there is a variety of quality of the individuals that come out of that program. That is ABEM's job, to make sure that every individual diplomat in emergency medicine has the capacity to practice competent, quality emergency medicine. And that is the goal of ABEM. Now, I don't want to get into a discussion about, number of training programs and training program requirements and things like that. But you can appreciate that given the entire cohort of residency graduates every year, nearly 3,500 residency graduates, there are going to be good ones that come out of some traditionally viewed as weak programs that are perfectly qualified, and there will be some less than competent physicians coming out of the best program. And that is ABEM's job, is to set that bar so that when any member of the community, member of the public goes to an emergency department, that there is an absolute assurance that they are being cared for by somebody who has the capacity to practice competent emergency medicine.
Yeah, and thanks, Diane. And I would just add that we already, in our current assessment process, we already know that every year, somewhere in the neighborhood of 10% of graduating residents are not able to actually pass the oral certifying exam. So we do think that we don't know where those numbers are going to go in the future, but we do think that that assessment process does set that highest standard that we're looking for. And knowing that no organization is going to have 100% reliability with an assessment process. So we know we need this to maintain that high standard.
All right, I'm going to switch gears for a minute because we have had a couple questions come in about the PD attestation. And there is concern from some of the participants about rating a candidate, a graduating resident lower for a competency, and that then being used to say that eventually down the road that then that candidate is not eligible to sit for the qualifying exam, and how that could increase risk to the program, increase risk to the PD. And so just wanted to get your thoughts as we move forward with implementing the program director attestation and the consequences of a program director saying no, that a candidate doesn't, or a graduating resident doesn't have this skill or doesn't have it adequately. What is the board's thoughts related to that dilemma that a program director is likely going to have?
It is a dilemma, and that smart group of attendees at this webinar who are pitching some hardballs, but we appreciate them because this is the time for us to answer them. We know from the numbers that there is a group of residency graduates from EM training programs who meet less than 50% of the milestones at the time of graduation. We also know that despite that number slightly increasing over a number of years, the number of residents graduating from EM training programs versus the number being held back for remedial work has not changed. So we are hoping that the PD attestation is a tool for program directors to use to say, I can't check this box. Therefore, this is something that you and I, as a working collaboration between learner and faculty, need to work on to become a competent emergency physician. We are using the program director attestation formatively during the initial stages of this rollout, just so that we can see if we can get an accurate idea on where some of those shortfalls may be and correlate those to the milestones.
And I would also add that I think as we do roll out the attestation, the new attestation form, we will want to perhaps tweak it somewhat going into the future. So we certainly will be looking to have feedback from program directors as we do proceed with the rollout.
Switching back to the certifying exam for a minute, just some questions related to if the cases will we be able to see linkages to the current milestones? Will we have that information? Are their competencies and criteria for the ASCIIs going to be published? What are the correlations to the milestones, et cetera? So kind of really trying to think about the linkages between the case types, the way the exam will be developed, and what the programs currently use in terms of milestones and competencies.
Yes, I think that there will be opportunities for us to give you those clear-cut linkages between the different case types and the competencies that we are hoping that our candidates will demonstrate in those case types. Was that the question, Kathleen?
Yes. Yeah, we will have that information probably as we go over the next, I think, 6 to 9 months as the program and cases get developed more robustly. Can you speak a little bit to how ABEM will be evaluating the effectiveness and doing quality improvement on this certifying exam as we go forward, thinking about just making sure that we're continuing to be better than what we're doing now?
Yeah, that's a great question, and I get to put on a little bit of a geeky psychometrician's hat for this, and saying that that ABEM has never been an organization that grades on a curve or has a set number of pass or fail for any given exam. Everything that all of the standards that ABEM comes up with are criterion referenced, meaning that the criterion that we're using to demonstrate what a competent emergency physician is are actually set by a panel of practicing emergency physicians who tell us what the standard is. And those panels are rotating, community, academic, newly practicing, a little longer in the teeth doctors come in and sit on those panels and tell us this is the expectation of competency in emergency medicine. This is the expectation for delivering quality care. That process of standard setting and using criterion referencing will continue and is extremely important for the new certifying exam. Making sure that we are benchmarking to an established standard and not benchmarking based on the novelty of the exam or the context of the assessment environment, or what we happen to be assessing now, which is a much broader set of skills than we ever have before. Competency is competency, and we make sure that that is always anchored in really that skill set that isn't thought up in a dark smoky room by a bunch of board of directors. It's really based on what a competent emergency physician who's actually practicing thinks is an essential skill set that's needed to move forward.
So there are a couple of questions, again, kind of coming to the variability in terms of resources available to graduating residents and candidates. And so, there's geographic diversity, there's just the programs from where they come diversity, et cetera. And so there is a question about whether or not ABEM would be willing to consider establishing potentially a scholarship fund or some way to offer that if candidates with lower resources have an ability to potentially apply to this scholarship to try to offset some of the travel costs for the exam.
Do you want to answer that, Ray, or shall I?
Sure, thanks. I do think that ABEM and the board have been looking at potential ways that we can try and provide, I think, assistance, especially those candidates who might require it. We have not come to any conclusion yet or reached I think, a final resolution of that question. But we do clearly understand that there are some hardships that this could create for some candidates, and the board is strongly looking at ways that we can try and defray some of those costs.
There's also a question that about the fact that residency programs vary in their access to simulation and sim-based training for their residents. And so they're looking for what advice that you all might have for those programs that don't have necessarily those resources or have the simulation that could help prepare their candidates.
Yeah, let me give some comfort and some reassurance to any of you that feel like you may be in that situation. The procedural competencies that we're looking for are not those that we're hoping to model off of a high fidelity, high tech simulator. The procedures that we're looking to model are really kind of everyday procedures that, an airway mannequin or a joint arthrocentesis mannequin would be able to give your residents in doing this. So I don't think that it's going to be necessary, nor is it advised that we maintain a focus on the $200,000 many man or anything that is high fidelity like that. The procedural competency that we're looking for, the ultrasound one is clear, that the core set of ultrasound skills should be demonstrated. But also the procedural ones will not be the high tech. They'll be more along the lines of a low fidelity simulator.
Can you explain the triage cases a little bit more?
Sure. The vision is if you're coming into an emergency department, you're coming in new on shift, and you see a track board that has 6 new patients on it with varying levels of acuity and varying suitability of vital signs and presenting concerns, that we would hope that a candidate would be able to prioritize which of those cases to go see first, and maybe even be able to delegate some of the care of the lower acuity patients, to either be started by or be completed by mid-level providers or residents that you happen to be working with, and how to begin to delve into that whole competency of team management when it's just you and you're feeling somewhat overwhelmed by a track board that is hemorrhaging, that you have a system or you have a rubric, or you can approach this in a logical manner to say, this is how I would begin to prioritize the cases that are put in front of me.
Interesting question about whether or not program directors and core faculty will have the opportunity to visit the AIM Center to do tours. We haven't really thought about that, but we could potentially set something like that up. And a couple questions about the pass rate. And I don't think, and I would invite you guys to comment at that. I don't know that we know what the pass rate is going to look like or how we're going to determine passing scores. I don't know if you want to comment on that.
Well, I'll say the board of directors has no appetite for having a 50% failure rate on our new exam. That being said, again, I have to go back to the fact that this is criterion referenced. This is based on a group of practicing emergency physicians in what is competency. If we think that there are elements of competency that a group of emergency physicians out, if the board of directors thinks there are elements of competency that a group of practicing physicians doesn't agree, then we have to take that into account, and that's where the criterion referencing really comes in handy. So we don't have an idea of a pass rate at this time.
I think, Kathleen, maybe you can shed some light. When the American Board of Anesthesia went to the AIM Center from their previous assessment process, there was not any significant change in the pass rates. Is that correct?
That's correct, yes. One of the questions is about the clinical decision-making cases and how similar or different they're going to be from the current standard or structured interview cases.
We found tremendous utility and reliability and validity of the structured interview cases, which do get to the candidate's thought process and why they're doing some of the things that they're doing. I think that those type of cases are well served in a tabletop or the clinical decision-making environment that we have designated for this in the new certifying exam. I think the standard patient encounters that were part of the virtual oral exam, and prior to that, the regular old oral exam, I think that those types of interactions and some of the things that ABEM was really looking to assess in the standard cases may better be served in an OSCE environment where you're actually interacting with a standardized patient as opposed to an examiner who's trying to pretend to be a standardized patient. So a structured interview I think has a higher likelihood making it through into the clinical decision making portion of the new certifying exam, but probably with a few tweaks to it.
A couple more questions on the PD attestation. Right now, the program director attestation in its present form is a yes/no. Is ABEM considering going to a rating scale, maybe in a future iteration? And do residents see the PD attestation form?
That's an interesting concept. Of making it a variable scale. I think that's one that I will take back to the Academic Affairs Committee. I think the response may be that that there is a set level of competency, and either the resident has met that or the resident has not met that. So I can see utility of it maintaining as a yes/no format. But I think the heart of the question is more likely how to incorporate the stepwise progression of the milestones into assessing that final outcome competency. And that'll be something interesting for academic affairs to take a look at.
So previously, volunteers, ABEM volunteers, oral examiners have not been able to help programs with the training for the exam. Is that policy going to change with the new certifying exam?
I don't think that we're looking for that policy to change. However, the definition of help may be a little bit different. We're planning on being as upfront and as transparent as we can about the content of the new exam as it rolls out. Looking at the specifics of a scoring rubric for any encounter, or looking at the specifics of the criteria that we're using for any encounter, that is privileged information for ABEM. And obviously we want these cases to have some longevity, so that can't get out to programs. So there will still be an embargo on those type of interactions and that type of information. But I think generally helping residents understand what the evaluation process looks like is something that the board will have to really come to a decision on as we roll out the new exam.
Can you speak at all to outside of ultrasound, any other types of procedures that ABEM is thinking about right now? Maybe ideas for the kinds of procedures that will be part of the procedural assessment?
So we are getting together with the case developers for the first time in the month of May. After that, I think we'll be able to give you more granularity on the specific procedures that we're looking to evaluate competency on. But there are a handful that are ubiquitous in emergency medicine. So, you know, is it fair game to look at airways, and is it fair game to look at central access and joint reductions and precipitous deliveries? And yes, it's fair game to look at all of those. So it would be hard for me to limit them to any specific procedure. You know, will there be a resuscitative hysterotomy? No, there won't. You won't be doing a crash C-section in the simulation portion of the testing. But the common procedures in emergency medicine, I think, are all fair game.
Thank you all very much for attending. We look forward to seeing you at court in a couple weeks. And this concludes the webinar.
Thank you.